First of all, welcome to today's discussion. My name is Tom Horner. I'm a board member of ServeMinnesota and delighted to have all of you with us. Just a logistical issue. If you have not yet found them, men's room is on this end of the hall, women's room on that end of the hall, coffee and water out there. Please feel free to get up and help yourselves as we go forward here. So today's discussion, the opioid crisis, the response from Minnesota, is the third in a series of forums hosted by ServeMinnesota on an issue that is affecting individuals, families, and communities across Minnesota. According to one estimate, the epidemic is costing each resident of Minnesota more than $1,100 annually, and these costs are only expected to rise. And of course, the full cost can't be measured only in economic terms. The epidemic is causing immense suffering and robbing our collective future of talent and productivity. So we hope that by the end of today, with your collective talent, we will have a path to solutions, especially on the public's role in financing treatment and recovery. ServeMinnesota is eager to be part of the solution. AmeriCorps Programs has the infrastructure to mobilize people to make a powerful difference in this devastating issue that is impacting millions of Americans. AmeriCorps actually has its roots in Minnesota. Senators Dave Durenberger and Paul Wellstone, drawing on the Minnesota tradition of community action, were central to the creation of AmeriCorps. And today, ServeMinnesota oversees one of the nation's most robust AmeriCorps state programs. We're delighted to have an audience of dedicated experts and professionals and a distinguished lineup of presenters today. We've also extended invitations to Minnesota's gubernatorial candidates or the lieutenant governor candidates to drop in as their schedules permit and provide an overview of how their administrations would deal with this crisis. If they or their lieutenant governor running mates are able to stop by, we'll adjust the schedule to accommodate them. And I also want to acknowledge the terrific support we have received from Butler Family Foundation, Allina Health, Regions Hospital, and Minnesota Hospital Association. This forum would not be possible without their generous support. So a bit about today's program and outcomes. As I said, we're thrilled to have the expertise and experience of today's presenters. There'll be an opportunity for you to engage with them in a question and answer period, and for those of you who have registered for the full day, at this afternoon's breakout sessions. The breakout sessions, I think, are especially important. They will be the opportunity for all of us to convert what we hear this morning into action going forward. The sessions have been designed by Leslie Crutchfield, who, as you will hear, is an expert on how social movements take form and succeed. And at the end of the day, we'll reconvene to hear the ideas that have been presented and to summarize the key findings. What we do today will be the basis for how we move forward. While we respect the specific agendas of the many people and organizations dedicated to solving this crisis, there is great value and urgency in finding common ground. Yes, there may be times when we will be, as Ms. Crutchfield says in her book, adversarial allies, organizations united in purpose, even if we sometimes diverge on tactics. Today, though, is our opportunity to move beyond the tactics to the shared values and strategies. That's what brings us here today and what will guide us to success. So to introduce our first speaker, I would like to welcome to the stage Phil Rutherford, who is the Director of Operations of Faces and Voices of Recovery. Phil will introduce our first speaker.
Good morning. Like you said, my name's Phil Rutherford. I just want to share a brief story with you guys. When I walked in, Audrey said, I'm really looking forward to you introducing Peter. And I said, well, you haven't heard what I have to say yet. I I just want to share really quickly before I introduce Peter, at Faces and Voices of Recovery, we are committed to helping with what's described as the opioid crisis. We recognize that opioid deaths have been happening, substance use disorder deaths have been happening for quite a while. So we're very interested in participating in whatever way that we can as an organization. It is my pleasure to introduce Peter. I had to bring the paper up here because I'm not super good at memorizing long titles, but I want to share with you Peter's previous title, Chief of the Recovery Branch and Senior Policy Analyst at the Office of National Drug Control Policy. And I think rather than simply, I assume everyone here can read, right? Anyone here can't read? No? Okay, good. I just want to tell you that one of the first things that Peter said to me was, I'm a person in long-term recovery. And that means a lot to me because I'm also a person in long-term recovery. And I think it's important to this particular effort that we bring both people in recovery and people not in recovery together to solve some problems. But Peter served in that role. He also worked at Alterum and has more than 25 years, is that correct, in this particular industry. So without further ado, I'd like to introduce you, Peter Gaumond.
Thank you, Phil. Good morning, everybody. If you don't mind, I'm going to try and set up the notes that I probably won't follow very well and a timer because I, believe it or not, have been known to run a little over every once in a while. All right, we're going to set that. All right, so early August, Kathy Hartnett reached out to me about the possibility of serving on a panel at this event, as she let me know that Chris Lawford was going to be keynoting, and I was very excited about that possibility because Chris is a real was a real champion of the field. And he's somebody I had the opportunity to connect with maybe once or twice a year. But we go back a number of years, and we've been in dialogue on various things. And I knew that when Chris was here, he could carry the message in ways that few other people could carry it. He was powerful as a speaker. Then we learned of Chris's sudden, unexpected passing. And shortly after that, Kathy and Audrey reached out to me to see if I could, quote unquote, take Chris's place. And, you know, of course I can't take Chris's place. But what I can do is share a little bit from my experience as a person in recovery, and also then shift the conversation a little bit to talk about the current landscape, what we know about the epidemiology, what the federal government is doing, to just lay some general landscape. So I first want to start with a little bit about myself. But even before that, I just want to say that Chris is somebody who made a mark that will continue to have an effect. And he was instrumental in so many things happening. I know at the time that he passed, he was on the cusp of relaunching his foundation, his Global Recovery Initiative, to try and bring it to another level. And we need leaders of the kind that, of Chris's ilk. We need them badly in this field. And so he will be sorely missed, and it's time for some of us to try and fill in the ways that we are able to for Chris. So about my story, I don't want, I want to start first and foremost, just as Phil did, from today by saying my name is Peter Gaumond, and I'm a person in long-term recovery. And for me, that means that I haven't needed to use alcohol or other substances since December 2nd, 1986. But more importantly, it means I have a family, I have a life I could never have imagined. In fact, as I'll talk about, I couldn't imagine much of a life of any kind at one point. And I'm able to do work that I'm passionate about. And maybe sometimes what I do makes a difference in some other people's lives. And being able to be of service, as I know you know, is a gift in and of itself. And so today I have a lot to be grateful for. And when I say, when I talk about recovery, I'll talk a little bit later about this in the slides, but I'm talking about a process. One thing I always say is abstinence is not recovery. Recovery is not abstinence. In fact, if you went out and asked who wants to sign up to be abstinent, I don't think you'd do very well. If you've been around the 12-step rooms at all, you'll also know the story of the dry drunk, the person who has all the care, just as terrible as he was before or she was before, but they just don't happen to be consuming the alcohol or perhaps the drugs. Abstinence is a tool for achieving a different life, and it is not, if it's your end, I think you're going to be miserable. Certainly, it was my end in many ways for quite a while. My story with alcohol goes back to childhood. I don't know the exact age, I don't know the exact location, but I remember vividly it was a family or a friend's gathering outdoor, one of many we used to do when I was a child. And there was a little white tent, and there was a card table with lots of liquor bottles and partially full glasses left on it. And I think I was probably orbiting it, looking for my opportunity to kind of check out this magic elixir, because I'd seen the effects of alcohol. It made people happy, it made them sing, but sometimes it made them terrifying, turned them into monsters too, my father. And I do remember coming up to that table, and I remember not being a lot taller than the table. And I don't think that anybody knew this, that I did this, but I then took a sip out of something, God knows what it was. Somebody's partially finished drink. But I do remember this feeling that started coming over me immediately. And it kind of confirmed my mythology of alcohol, that there was something magical about it, that this was something very powerful. And I think that, in a sense, started my journey with alcohol. And through my high school years, it would get better and worse. I was at a private, my parents, my brothers and sisters stayed at home, but my parents sent me away to a private boarding school, a military academy. That may give you an idea of how things were going. And I almost managed to get kicked out, I think right before graduation, on happening to get caught on one of my trips going to get alcohol with my NIPCO ID, which I had purchased from the back of a magazine, which was hermetically sealed with a fake fingerprint on it that said that I was 18, which was then the drinking age. And it continued to be a problem for me. As things got worse with my father, I ended up reading a book that really hugely affected me, and that was Under the Influence by Kathy Ketchum and Dr. Millam. And it helped me understand what was happening in our family, but also, unfortunately, it helped me understand or see what was happening with me. So like people in 12-step programs sometimes say, it kind of ruined my drinking a little bit, but it certainly didn't stop it. You know, I had a theory that the reason I drank compulsively, I was getting very sophisticated about this, was that because of all the trauma I had experienced as a child, I needed to self-medicate. And that if only I could resolve that trauma, if only I could move to the other side, then I wouldn't need to drink compulsively. I just didn't seem to notice the ironic next step, and therefore I could drink. You know, that in fact, over time, it became apparent that that's all that mattered. And over time, and I was one of those people that worked to segment my life, to have a perfectly normal life. I would drink before events. I would, I had a high tolerance. I would then, after the events, I would have to drink some more alone. So I knew I had a problem, but I always kept on saying, I'm going to deal with it, or I'll figure out how to deal with it. It was always something that I was going to deal with. And long story short, it took quite a number of more years before I got to the point where I did deal with it. For me, that came when my then girlfriend stopped by unexpectedly in the middle by my apartment in the middle of a work week, which of course I was home because I wasn't employed at the time, and found me once again 4 sheets to the wind. She came in, I tried to stuff the bottle. I drank liquor at that point because it's much more efficient. Why deal with the other stuff? Because you need to get the effect. And she just said that was it. And for some reason, I knew she meant it, and she did, and she walked out, and she left. And for some reason, that was the moment where I had this light bulb moment, and it wasn't a cognitive light bulb moment. What happened was I kind of just fell against the wall, and I said, oh my God, I need help. And it's like, no kidding, duh. But cognitively I knew that, but what happened was the shift was that I had surrendered to be willing to ask for help and to seek the help in good faith. And I recognized that there was no way out of this. And I had reached a point when I was in high school. My idea, I was by the end of there, I was getting in all kinds of trouble. I continually got, I'd get up maybe as high as sergeant and get busted again and get all kinds of, penalties at the military academy. But academically, I was doing great, and I was on a independent study track. And I said, I'm going to go through and just become a PhD psychologist, and then I'm going to do this, and then I'm going to do that. And I had all these passionate ideas about what I was going to do. By the time I reached that point, I didn't care. It didn't seem to make any difference what I did. And I also I couldn't imagine a life without alcohol. Alcohol had slowly but surely taken up the space from everything else in my life. And it was my connection, albeit problematic, to my own feelings. It served as a kind of bridge to others, but really it was kind of a solipsistic world. I didn't realize that I was really just so isolated. And when that was gone, there was nothing there, and nothing seemed to, and I had no hope. For some reason, I couldn't believe that there could be anything better, that anything could ever change. And that has changed remarkably over the years. For my first 20 years in recovery, I never spoke publicly as a person in recovery. My friends, family knew that I was in recovery, and most of my friends were in recovery. But there were some issues with insurance. There were some issues with concerns about professional consequences and so forth. But when it came down to it, it was after I moved to DC, I started working for this, for APT Associates, supporting a SAMHSA program, Partners for Recovery. And I'd always admired people who did speak out publicly, and I saw how important that was to overcoming the stigma. So finally I said, listen, you can't just continue to sit on the sidelines. You have to do something yourself. And, I had, in part, I had experienced the who am I to speak for recovery. And in part, I was worried about, well, am I going to see myself as Mr. Recovery? But really, what happened was, for me, it was really liberating because I recognized that I still was segregating my life in a way because of the stigma associated with addiction that I had internalized. That I, despite my belief that, and there were some rational reasons for doing what I was doing, that really I was still segmenting this recovery life from the other public life. And it's not that there need to be no boundaries, but it's that there's no reason I don't have to acknowledge that I'm a person in recovery. And that I can acknowledge it if it's helpful at the time, and I don't need to acknowledge it or talk about it if it's not helpful. And that to me was liberating because actually that was a sticking point. What do you do whenever that comes up in conversation? And each moment I'd have to kind of, navigate that. It's not really a problem for me right now. But what has really changed is that I have been able to lead a life that I could never have imagined, doing work that I care passionately about. And one of the things that I see about the work that you do, those of you that are in the AmeriCorps and Vista, is that you get to do work that is of service to others, and there's no greater gift to yourself, in my experience, than being of service to others. And as a former Peace Corps volunteer, I think I have a sense of some of what you do. I know it's a little bit different. Let me come back to since I left my notes on the side here. I think I'm going to, here's what I will say, is that just as my recovery was transformative in my own life, I know that recovery among individuals and among groups is transformative not only among families, but at the community level, that there is a power in this process, and that this community needs to find a way to better channel that power, to find shared objectives that we can all pursue, and to get more on the same sheet of music. We can always agree to differences, but we have to move forward. And I think that the AmeriCorps platform, what you guys do, has the potential to be an incredible opportunity. You have tools that you can bring to bear to create change, or to create the platform for change to take place, I believe. So I think that the discussion today is incredibly fitting, and I'm really looking forward to that. Now I'm going to, I guess I'm doing a 30-hour remark. Okay. All right, so I'm going to go very quickly. So how many of you are familiar with the SAMHSA definition of recovery? A few of us. So I think the key here is that recovery is a process. It's not an event. And if you are familiar with the stages of change and motivational interviewing, you'll know that, the way the process works, typically abstinence is not going to be the first step. It may happen at the very beginning in some cases. There's nothing to say it doesn't happen that way. But typically, you're in contemplation. I really do have a problem, but I'm not ready to deal with it. You're in pre-contemplation, then you're in action, then you're in maintenance. And some would say you get to termination, some would say you stay in maintenance, depending upon their vision of recovery. That's one of the things that I think is really important, is that we need to embrace all the different pathways of recovery. I wouldn't want anybody to tell me whether or not I'm in recovery. I can answer that question. I may not be in recovery according to their criteria. That's okay, and vice versa. And so what is essential? It's a process of change. You're moving towards improved health, wellness, dimensions, health, home, sense of purpose, community. These are all the things that are, if you will, the mirror image of what addiction is. Poor, your health going downwards, lack of a home, either literally or figuratively, lack of purpose and direction, and disconnection from community as your primary relationship shifts from others to a substance. So this is exactly the inverse of that. And so I think that's what we need to look at, is how do we foster this process of recovery? And I think your outcomes are going to be better in the long term if you're looking at how people are achieving these milestones, as opposed to counting specific days of abstinence. It's great that it'll be in October, if everything goes okay, that'll be 32 years for me, but quantity isn't quality. Those are two totally different things, and those can shift very rapidly in the recovery process. I know that from my own experience. And I can tell you that first year, there was no quality there for me. It was fingernails, and when I finally put together a year after trying multiple times, I was astounded. How in the world could that have happened? Well, it happened incrementally every day by me reaching out and getting the help I needed and getting the support I needed. Now my needs are different than they were at that point, as I've changed in my recovery process. Core messages that are really essential. Addiction is a disease, and it's not the result of a personal or family failing. And despite the fact that we will probably almost all say, oh, yes, that's true, many of us still have, I certainly probably, I'm sure I know I still have some of that residual learned stigma about this condition, even though I do speak out about it. So that's part of my healing process, is speaking out about it. Addiction can be prevented, and it can be treated, and people do recover. Language matters. John Kelly, who I think you've had some involvement with, did a really interesting study. He was at a conference, and he got together 400 and some doctoral level, I better speak into the microphone, got together some 400 plus doctoral level mental health and addictions clinicians, and he gave them an identical vignette. How many of you are familiar with this story? Okay, hardly anybody, good. And the vignette was identical, except that the subject of the vignette in one of them was described as a person with a substance use disorder, and in the other vignette was described as a substance abuser. And then John administered his battery of instruments after the study, and lo and behold, the clinicians randomly assigned to the substance abuser condition were more likely to incline to concur with the need for punitive measures, to attribute responsibility, blame to the individual. So if that, and I would have thought that this group would be relatively immune to that effective language. A similar study with a different population found a much stronger effect, not surprisingly. Other studies have shown that negative attitudes towards people with addiction among healthcare providers have result in, this was a meta study, it found that the attitudes resulted in routinized care, lack of patient empowerment, and poor health outcomes, all because of the attitudes of the providers regarding addiction, which is in part because we've had a bifurcated system and we haven't trained our general health professionals in addictions. We're making progress. Finally, we need to educate the community. So let me move on. I'm probably running a little, what do we have left? Do I have 5-7 minutes, okay. Recovery support services, which is one of the things that you are working on here. They're essential, and they're really new. They're not the same thing as mutual aid, 12-step meetings, smart recovery, and so forth, because ideally they are pathway neutral, whether you're taking medication or not taking medication. And what condition is there where you'd say, I'm being treated for condition X, and I would qualify whether or not there's medication involved in my treatment? There's a certain way that the field has had a difficult relationship with the medical field, with medication and so forth. But it needs to provide a bi-directional link. People can can be engaged through the community, linked with treatment, and people can come from treatment to these community supports, and these organizations often provide a pathway in and of themselves for individuals to recovery. And we'll look very briefly in a minute at some general data about the trajectory of people with alcohol and drug problems. You'll see that a large number of them don't actually go through treatment and reach resolution. So we have an emerging recovery support services infrastructure. I don't have time to describe these various things, so if there's any questions about that, I'll bring that in. We're seeing a growing range of roles for the peer worker. From the traditional peer recovery support, recovery coaching role, we're now seeing outreach and engagement in emergency departments, community outreach, even harm reduction related activities. Not only the naloxone, but doing outreach in communities. And we're seeing when when they attempt to engage individuals and are not successful, for example, following an overdose, in some cases they're saying, I can still be a resource to you. Stay in contact with me. If you need clean syringes, here's where they can be. If you need this, if you need that, here's where you can get them. So there is a range of roles. You got your pick? Okay, there, good. All right, and I'm happy to share these slides. So if we look at, here's what I call problem resolution versus recovery. This is another study that John Kelly did fairly recently, where he looked at a population sample, and he found that about 9.1% of those who participated in the study reported having had an alcohol or drug problem and having resolved it one way or another. Carried out in the population, that comes out to about 22.4 million, which is about what other estimates have come to. The challenge we have in this area is if we're trying to measure recovery, not everybody who's resolved the problem will say they're in recovery. And because a person says that they resolved a problem, we don't know the severity of that problem either. So there's a lot of gray area when we're looking at this. What are these trajectories? So I think the approach that John took makes a lot of sense. Let's just describe what we find. He found that just under half, 46.6%, self-identified as in recovery, and that 54% reported an assisted pathway, which meant they went to treatment, mutual aid, or received other kinds of support. Now, isn't it interesting that a larger number reported a treatment or other assisted pathway than actually describe themselves as in recovery? So that, I think, gives you a sense of what are we talking about when we're talking about the recovery community. In part, we're talking about a community that is a subset of those who had an alcohol or drug problem, who self-identify as recovery and as in recovery. And so the charge here is to be as broad as possible, not only to those in recovery, but of course, if we're trying to build a movement, we need to bring in everybody else. That is not just those that are in recovery or the families of those with addiction. So that's another challenge. So over half reported that they had mutual aid, took part in mutual aid. 27% reported treatment, and 21.8% reported recovery support services. That's notable because as a category, that didn't really start to exist till around late 90s. There were some rough equivalents that existed, but it wasn't really recognized as a separate entity until I think the SAMHSA Recovery Community Services Program began in 98 or so, in 98. What they found, use of assisted pathway was associated with having a diagnosis, and it was associated with greater problem severity as they could determine it through their instruments, and that individuals with opioid use disorders were more likely to use an assisted pathway than those with alcohol problems, who in turn were more likely to use such a pathway than those with marijuana challenges. Very quickly, the opioid crisis. Are you mostly familiar with this data? Yes. So the latest estimate in 2017, approximately 72,000 Americans died of opioid overdose. A way to look at that is 197 deaths a day, or if you want, think of a commercial airliner falling out of the sky, a jumbo jet every couple of days. That would be another way of looking at the scale of this. We lose track of that because it's not out there visible in certain ways. And we lose track of it too, I think, because people can say, well, yeah, that's terrible, but it doesn't affect me or it doesn't involve me until it does, or until it does involve their family member. So that's a 13% increase from 2016 to 2017. We have seen some flattening of the, and here's the overall trend so that you can see that drug poisoning has been just taking off as the leading cause of unintentional death, accidental death. And then we look at the drug types there. By class of opioids, what you see coming up right here, synthetic opioids other than methadone, that's your fentanyl. And we're seeing a leveling. We're beginning to manage the prescription, the prescribing, and that's starting to level off. The problem is we've now got fentanyl in the general stream, and that is creating a much greater risk of overdose and fatality that we're seeing here. so that the fatality numbers can continue to go up even if the total number using doesn't go up that much because of what we're experiencing with so that's a key issue. Second of all, a study, the vast majority of people in the U.S. have private insurance. A review of private insurance data showed that of people with an opioid-related hospitalization, only 10% received any medication for the treatment of opioid use disorder, which is the recommended form of care, and is associated with lower risk of subsequent drug use, better treatment retention, lower likelihood of overdose and mortality. And so there's a problem. There's a problem here in that we're not delivering the care that people need, and we're putting them at greater risk because of that. And so that's one of our challenges: is how do we improve the approach to care for the opioid crisis? If we look overall, addictions is a unique disease as well. If you look at the National Survey on Drug Use and Health, only about 10 to 11% of those who are estimated to need treatment actually access it. That compares to 80 to 95% for most other chronic conditions, receive some form of care, whether it's diabetes or so forth. Why is that? Because we don't talk about it, because we don't screen about it, because our health professionals aren't trained in it, because we still have that shadow of stigma, because we're concerned about what others will think if it came out that we had a problem, or that our employers would think, or that we might lose our job, or that we'd have legal consequences. All these factors pile in there to create a problem. The good news is we actually do better with opioids than we do in general. So about 20% of those with opioids receive treatment, but if I recall correctly, only about 20% of that 20% actually gets medication in the latest data that I've seen. Treatment referral source. This speaks to the problems we've had with a segregated system, and what better to bridge systems than some work such as you do. If we look at this, the primary referral sources are self or individual or court or criminal justice system. Wouldn't you expect it to be referral to specialty care from another health provider? I think this speaks volumes to what we're not doing. That is just very basic, that has to happen in healthcare. And I also think it speaks volumes to the need to continue to work to integrate addiction care into the broader health, mainstream health systems. There's definitely a need for specialty programs, and they need to be linked with and connected with the other healthcare systems. They can't be out on a limb somewhere by themselves. 3 medications approved. I'm going to move beyond that because I think I'm running out of time. So the federal response, you're probably all aware, or mostly aware, that the President Trump convened a commission led by former New Jersey Governor Chris Christie to make recommendations on addressing drug addiction and the opioid crisis. We at ONDCP had the privilege of staffing that commission and working on the recommendations. We didn't agree with every recommendation, but we also were able to help form some of those recommendations, and that has made a significant difference in what's happening in the administration. It has become a really important guideline to the work we're doing. And at ONDCP, what we do, our essential job, is coordinating drug policy across all the federal agencies. And then there was the declaration of the public health emergency. That provides some additional flexibility. It's not a cure-all. And even if it were fully appropriated, the amount of money statutorily available under that part is relatively modest. So there's no panacea in that particular declaration, but it does help provide flexibility. The state targeted response and the state opioid response grants, the latest grants that came out, those are efforts to get the resources to the communities where they need to be. going out to states. Every state will participates, but the states that have higher rates of opioid use disorder will get proportionally higher portions of that. Minnesota has done some important work through its SDR grant, and I'm sure is going to be doing more work under its SOAR grant. The president has an initiative that is administration-wide that includes a media campaign working on safe prescribing, which is essentially, again, fostering the use of the CDC guidelines and other documents, and research and development, and interdiction. Especially the fentanyl issue is something that's particularly challenging. HHS has a 5-point strategy. I'm going to be able to talk to people about these initiatives afterwards because I know I'm running out of time. The HEAL initiative is a high-level initiative to develop new treatments for opioid use disorder and to develop non-addictive treatments to pain and chronic pain that has been, it's a keystone initiative for NIH. Medicaid, 1115 waivers, those who know that world, that allows a state to propose a way of doing business that is a little bit different, and under these waivers, they can propose let's say, new payment incentives to encourage continuing care and coordination of care. They can request waivers to requirements such as the IMD, or Institute of Mental Disease restriction, which classifies a residential treatment program as an institution of mental diseases, and says specifically that no institution of mental disease can be reimbursed, and defines it as over 16 beds as an institution of mental disease, and says no such organization can be reimbursed through Medicaid. So that eliminates, what it does is it creates replication of efforts, loss of economies of scale without any, there's no clinical reason for the 16-bed number. And so a lot of states are looking at that. Then screening, brief intervention, and referral to treatment. This has been, SAMHSA has been doing this since the 90s, and it's critically important. And based on the data you saw there, it still has a long way to go. That's a structured protocol for identifying a person with a possible alcohol or other drug use problem, and their likely severity. Is it a hazardous? Are they using are there a problem use? Is there a likely substance use disorder? And based on that, they can provide brief advice, do a brief intervention. It can include something called brief treatment, or it can be a linkage to treatment. The linkage to treatment is always the difficult part, because now you're talking usually primary care or hospital in the connection with community-based treatment, which has been one of our challenges. And the provider's clinical support system, and the MAT PDOA, there should be a space there, grant program, those are two things that SAMHSA is doing. The PCSS is through the American Academy of Addiction Psychiatry. It provides training to physicians to obtain a waiver to allow them to prescribe buprenorphine for the treatment of opioid disorder, and gives them peer-to-peer counseling, training, a lot of other support. And the MAT PDOA grant goes to states, and it's focusing on eliminating barriers to providing this care. What is it that, and there's research on this, and what is keeping more physicians from doing this? An overview, very quickly. This is kind of the way that we like to conceptualize our world. We'd like to see it as a cohesive whole, where everything from prevention, treatment, to recovery is part of one overarching strategy. In the real world, when we come down to implementation, we have a lot of separate siloed funding systems, regulations, and so forth. So our challenge is always to try and say, how do we move these in a coordinated way? And we need some kind of glue such as peer recovery support services can provide, and such as volunteer organizations can provide. And the last thing I'll say is that if you look at the two ends, prevention and recovery, you can really picture that as a circle, because when you're supporting recovery, you are doing some of the same things you want to do when you want to conduct primary prevention. You're building resilience. you're building resilience in the community, not just among the individuals, but that can have a ripple effect, and that can build resilience in families. If you're doing work in schools, recovery high schools, alternative peer groups, which is an after-school model, you can be supporting concurrently both your primary prevention goals and your recovery support goals. And so I think that's the beauty of it, and there's an opportunity to better integrate those. I don't see that happening at the national, policy level. I think that has to happen at the ground level in states and communities. I don't know if I'm probably a little over, but if there is time, I'd be happy to take questions at that point.
Let's hold on to questions for now, and then we'll come back and if you can stay around. This has been
Yes.
a great overview.
Thank you.